Hello and welcome everyone to today's ASIPP webinar, COVID-19 Coronavirus Webinar for Interventional Pain Management. I am sending out a poll question right now. If you are using telemedicine, must include both audio and visual communication, what platform are you using? A vendor that charges a fee for software such as SnapMD, Zipnosis, etc., a free telemedicine service such as Doxy.me, IntelliHealth, GoTelecare, a virtual conference app such as Zoom or Jitsi, a video chat app such as Skype, FaceTime, or Google Duo. It is now my pleasure to introduce Dr. Laxmaiah Manchikanti, Chairman of the Board and founder of American Society of Interventional Pain Physicians and co-director of the Pain Management Centers of America, and Dr. Amol Soin, First Executive Vice President of ASIPP and CEO of OSIPP. Dr. Manchikanti, if you're ready, the floor is all yours.
Thank you. Thank you, Anjali. Thank you, everyone, for attending this webinar. This is the first of the ones we are doing. We have been doing letters on a daily basis. We have been pretty much in the forefront of this, doing from the beginning. We will try to finish this on time. We have a lot of subjects to cover, but it won't be covering everything. I'm getting many questions on what is happening. Why don't we lobby for seeing patients and doing the procedures right now? Why do we have to have a lockdown? And can we see patients with the barriers? And numerous questions on telemedicine. New CPT codes, how do we do high-risk procedures and low-risk procedures? Can we do clinical trials? So, multitude of questions. Today, we may not be able to answer all the questions. I want to thank the faculty, task force, ASIPP board, membership, and staff for putting this together. Today's scope of webinar is we are going to discuss some of the scientific aspects, health policies, economics of our practice, macroeconomic policies, how they are going to affect us from Washington or Euro Union or some other place. So we still have multiple issues remaining. Other than that, we always get a headache. So the warning is that don't look at your financial reports right now. That is going to cause you major headache. On next Friday, we are going to have the next one. It will be moving forward beyond coronavirus and the COVID-19 pandemic, clinical practical issues and burnout, essentially for the survival of interventional pain management. After that, we may have another one if we need to. As you know, it is very difficult to cover all the issues in one 2-hour webinar. Probably it will require 16 hours or so. So here we have the enemy. You can look at the enemy right there. Now, a little bit basics about coronavirus pandemic, otherwise known as COVID-19. WHO is saying that it is a pandemic because it is the worldwide spread of a new disease. Whereas our US CDC says that pandemic refers to an epidemic that has spread over several countries or continents, usually affecting a large number of people. Essentially, this is a geographic spread, not about the severity of the disease. So nobody may die, we can still call it a pandemic. Very few people can die, we can call it a pandemic. What is the next step here? What is SARS-CoV-2, that is the severe acute respiratory distress syndrome, coronavirus 2, SARS-CoV-2. The disease is called COVID-19, that is coronavirus disease 2019. Possible origin from Wuhan, China. It is the same strain we found it before, CoV-1, also from China. It affected about 8,000 people and 800 people died. Then we had this Middle East respiratory syndrome, COV, that's also same thing from Saudi Arabia. With 2,500 cases and 800 deaths, we had only 2 deaths in USA. What is interesting is even though we had 2 of those before and we are having the third one, we still don't have a vaccine. So developing a vaccine for coronavirus is going to be a very difficult issue. As we all know, it goes through the nose, mouth, and eyes. It attaches to the cells in the respiratory tract, producing a protein called ACE2, like we use in our medicine, ACE inhibitors. Each infected cell can release millions of duplicates of the virus before dying. But the major issue here is the cytokine storm. In serious cases, the immune system can overreact, attacking the lung cells, producing a cytokine storm. This leads to acute respiratory distress syndrome and possibly to death. Interesting thing I found today is that soap destroys the virus because its molecules can wedge themselves into the membrane and break it down. Another interesting thing I found out just 30 minutes ago, my friend Alan Kay, is that our masks may not provide any protection at all. We are trying to spend a lot of money for that, but it may not be useful. It is highly transmissible. Each person can infect 1.6 to 2.4 other people. It disproportionately affects the older people. Mortality is much higher. In younger people, mortality is 0.2%, but in older, it is 3 to 4 times higher. Many factors are unclear. This is the graph we keep talking about. So we are at the peak, and then we have to come down. It goes on. So we really don't know where we are. Looks like we are at the top of the peak. And hopefully it will come down. If you look at this picture, that is what it looks like. We have 85,435. That was yesterday. Today it is higher. So we are in the peak compared to others, but we are looking at the total number of exposures in our country. Worldwide, these are the numbers. I'm not going to read all those things, but in China, they had 3,200 deaths, and in USA, 1,300. Now, looking back at the infections, they are saying that United States is the highest one right now. If you look at this table, the red shows 82,583. That is true. We are highest. This is all based on how many people you test. More people you test, more positives you get. But looking at what is the prevalence, total number of cases based on 1 million population, that is 259 per million population. The same way, look at Italy, it is 1,333, Spain 1,370. So we are much lower level. Deaths is also 4. So overall rank is 8, not number 1. So it all depends on our presentation, just like evidence is in the eyes of the reviewer. Now, coming to each state, the New York has the highest number of deaths and cases, 2.4 per 1 million population in New York. Other states are much less. Texas has 0.1. Louisiana, they are really talking about that state becoming an epicenter. It is 1.8. That is pretty high. So this is, some of you guys who are from South India, you would know, this is a comedian. He said that I never thought our death would also be made in China. So we took action in the first place on March 16th. This is our ASIPP statement. We sent everyone, all the members, informing them about various issues. As always, patient safety above all else. Follow CDC guidelines. Follow your local guidelines. I'm not going through the whole thing. At the end, we had these 2 drugs for patients diagnosed with COVID-19, chloroquine and hydroxychloroquine. Since then, studies have been published. We also talked about using expanded mesenchymal stem cells. This is the manuscript which is just published. we are requesting the FDA to approve this for this purpose only, limited purpose, by minimizing the regulatory burden, instituting appropriate safeguards, and also providing with appropriate informed consent for limited purposes. We also have a lot of issues related to telemedicine, healthcare provider fact sheet. The simple thing is that we want to be able to use this just with telephone calls, no video, just audio, not both. President Trump's purpose is that to have only audio, but then all the other people are interpreting it differently. One day they are saying that you need only audio. The second day they are saying you need audio and video. It keeps going on. He also signed the Family's First Coronavirus Act. There is some money for us in this also. Amol will be talking more. Then on March 20th, that is almost 4 days after we issued our request, CDC gave clinical guidance for surgery. Then there is the stimulus package. There are about $100 billion available for entire medical profession, but $67 billion goes to hospitals. There is also a small business loan area where we will be able to apply for loans, and there is also a column for forgiveness. So Amol will be talking about multiple these issues, and we will also discuss more in our next lecture. So overall, a major recession seems to be coming. Stock market dropped one day, we went into recession and came up to bull market again, and maybe going back to bear market. If you look at all the industries, there is something missing in this. I don't see healthcare. So obviously some people don't think that healthcare is that important. Now today, there is going to be talk on various aspects. Dr. Davie is going to talk about medical aspects of coronavirus symptoms, diagnosis, treatments, background. Then Vanila Singh is going to talk about national and California coronavirus reference. Again, navigating multiple agencies for patient and physician safety and survival of business. Amol is going to talk about Ohio issues and the role of early interventions. Ricardo is going to talk about telemedicine options. Amol is going to come back and talk about business and economic impacts and tips for survival. After that, we will have question answers. As of now, there is only 10 minutes, but we can extend this if you have a lot of questions. So this is Dr. Devi. She wrote this book on coronavirus made simple. That is Akira, that beautiful girl there. And now Dr. Devi is going to speak. She is a wonderful speaker, physician, above all, great human being. She is an ASIPP board member, journalist, and family friend. Here, Dr. Devi.
Thank you, Dr. Manchikanti. Thanks for the kind words, both about me and Akira. And thanks to all of you for joining in. You know, this is so unexpected that this would come and kind of devastate us all this way. I will just say, in terms of my background, I'm working in New York, in Manhattan. I have a private practice affiliated with NYU, and I work in the financial district, which I'll say in this area, we're getting hit both with the health issues and just the financial aspects of this crisis. So what I'll do is just give a little bit of background about the coronavirus itself, just the medical aspects, and then, kind of building on what Dr. Manchikanti already said. And then I can talk a little bit more about specifically like what we're doing now in New York. So first, in terms of the symptoms, there's a lot of debate about it. When it first came up, people would say the classic symptoms are cough, fever, shortness of breath. Those seem, like things we might check for anyway before we do a procedure. We ask patients if they have fevers, chills, any signs of illness. But then as more research was done, a lot of the reports came from China that these patients had other symptoms, it seems, before all of that started. There's some reports that they couldn't smell, they couldn't taste well, they had sore throat. Now people are talking about, well, they could have had nausea, vomiting, some diarrheal type illness. There's a lot of variability in terms of the presentation of this. And I'll say, like, you know, we had patients come in. Now I'm wondering, because we're getting a lot of calls from patients that they have now tested positive for coronavirus. The exposure might have happened a couple of weeks ago. You know, we have patients just routinely coming in that might seem like they have allergies, acid reflux, who knows what. They don't always tell us if they have symptoms. But it seems to me one of the dangerous things about this is that, you know, people don't always have symptoms right away, so they can be asymptomatic carriers. There are a couple different studies, one that said 6 out of 7 people might be asymptomatic, another one that said 4 out of 5 people might be asymptomatic. So hard to tell. And then in a couple other studies, when they looked at, well, how long does it take between the time a person gets exposed to the time they might develop symptoms if they're infected? For the most part, it happened within 5 days, but there are some reports that it could take longer. So almost everybody is captured within 14 days, which is how the idea of the 14-day quarantine came up, that, well, if people don't develop symptoms within 14 days, then it should be okay. Problem is, even in that study, you know, they found people, this was in China, that took up to 27 days to develop symptoms. So, you know, even if it's a small chance, it's still possible that people could be asymptomatic for a bit and then suddenly develop symptoms. Now, I was talking about the mild symptoms, so the people we might see sort of on an outpatient basis who might have walked into our pain clinics. But I also, you know, so I'm affiliated with NYU. I also have, you know, family that works there. My sister-in-law is an anesthesiologist, what all she does right now is basically intubate the people who are in ARDS from the coronavirus. She's on a special team to do that. And my brother's a cardiac anesthesiologist, and he's doing something similar, plus managing some of the other cases that are going on. But from everything they tell me, it's pretty bad. Like, these patients, it's a rapid decline if they have these symptoms. You know, they might sometimes seem okay. They don't even complain of anything except fatigue maybe. Sometimes they're reporting something else, going in for a CT scan or a chest x-ray for something else, like a dislocated shoulder or whatever else. And then suddenly they find these infiltrates. So I've also been looking at these chat rooms, and some of the symptoms, or I shouldn't say symptoms, some of the signs that people have are that they have bilateral infiltrates on their chest x-rays, usually the right side. So even if it's just one side, if it's the right side, they presume that it's coronavirus. Some of these ground glass opacities, and then of course ARDS. And then, you know, the idea is that if they crash so quickly and they stay on ventilators for so long, you know, how will they do? So some of the things that New York has done, we kind of moved very quickly through these, but we started out with the social distancing. I mean, that was, I think, just 2 weeks ago, they were talking about social distancing, less than that even, that, okay, we'll stay about 6 to 10 feet away from each other, and then it should be fine. The concept, the reason for that was that if a person coughs or sneezes, you know, typically they don't get these germs further than 6 feet from you. So usually it's within 3 feet. So if you're standing at a comfortable distance from someone else, the chance of you getting infected is much lower, especially if that person is washing their hands, you're washing your hands, you know, you're not having close contact, you're using the hand sanitizer, you're careful not to touch your face. Thought that that was pretty much okay, but it didn't seem to be okay. So then the next thing was, okay, well, let's try being more aggressive about quarantining folks that might have any symptoms. So whether they have symptoms of coronavirus or any non-specific sort of viral illness or anything else, all of those people should stay home for 14 days. Anybody who's had contact with somebody who might have been to China, at that time they were saying China, but now we know it's the whole world essentially. But that, okay, you should stay in place for like 14 days. And then pretty soon afterwards, we suddenly have these shelter-in-place orders, which are essentially that everything is shut down. So to kind of give you the scope of what's happening in New York, pretty much everyone is supposed to stay in their home, not come out. we live in an apartment building where all the common areas are closed. So you can't really go to the lobby, the package room. It's got to be a very orderly sort of situation. There's really nobody in that area. There's minimal staff anywhere. We have amenities. All of those are closed. And then if you step outside, there's pretty much no one on the street. So people who might have wanted to take a walk, kind of keeping a distance, let's say, a week ago, that's not happening now. The subways, I checked this out because I had to go get some supplies, but the subways are closed except for a few entrances for some of the major stations. It's very, very limited. The cars are limited. The only reason they're running, I think, is to allow healthcare workers and some other folks to move around. Our office building, even if I wanted to open my office, our office building is closed for the most part. I think they're keeping somebody there just so that everybody doesn't get robbed in the interim. And then all the schools are closed, daycares, all of the stuff seems to be closed. So it's pretty serious. There's police on the streets in their cars. I don't really see too much else where we are. And then kind of getting into, why such extreme measures if it's really from coughing and sneezing up to 3 feet. Well, part of the reason is maybe surface spread. So this actually came up in a study way before New York took these extreme measures. These virologists, they did a study. It was funded by the NIH where they aerosolized the virus. So basically sprayed it on different surfaces. And they found that if it was aerosolized, it could stay in the air for 3 hours. It could stay on cardboard for a day, and it could stay on metal and plastic for up to 3 days. So now the concern is in places like subways and things like that, well, even if they're doing more aggressive cleaning, they really can't clean it after each and every person comes in or comes through. So that's another problem. Here also we have a very high density of people very close together and a lot of traffic. So for all of those reasons, I think that's why New York is such an epicenter for this coronavirus. Going to diagnosis. So there's been problems since the beginning in terms of the testing. The test that came out is a PCR test, which means if it's positive, it's very unlikely, to be a false positive. That basically, if you've got a positive, the virus must have been there somewhere. Sorry, I'm getting another call. I just switched that off. But anyway, so if it's positive, the virus was there in order for it to expand. But there are some reports that some people might test negative initially just because they didn't have enough of a viral load at that time. So they could still be positive. Plus, because there were so many delays in testing, that there was the expectation that this virus was really coming from China at first, but in fact, it could have been coming from a lot of people who either traveled through China or interacted with people in other, cities and airports and countries. It's everywhere pretty much now. So the delay in kind of figuring out who might have had it and tracking the exposures, that's how SARS and MERS were controlled here. That's led to a problem. And then here, I could speak to what's going on in New York. I'm not sure about certain areas, other areas in the country, but the testing is really variable, whether you're going to have a test or not. So I'll just say, for some of our patients, they've been calling. Actually, the office has been very busy with the phone calls, but they've been calling saying that they test positive for coronavirus. Their physical therapy site tested positive, so those sites are closed. Some of our, other physicians that we work with, their offices are closed because they've had coronavirus. And then for me personally, we know we have coronavirus in our apartment building. We know we have coronavirus in our office building. We know we had coronavirus in the daycare center that my daughter goes to. So even friends of mine that live in New York have, coronavirus, but problem is with testing. So even though the numbers already look bad in New York, the CDC has said it's only worth testing if it would change your decision making. So that kind of leads to a lot of variability, which means if a person has ARDS and they're being intubated, that person may not get a test because, you're presuming that they have coronavirus. If you have somebody who's in quarantine anyway and their family member already tested positive, that person may not get a test because they're going to be sort of in their home regardless. And even some of our patients who call me, because what's happened is the primary care physicians are overloaded. A lot of people are going into the hospital setting. So we're fielding a lot of these calls, I would say. Almost all of the calls are something related to coronavirus. But I've been advising some of the vulnerable patients, I'm not sure if it's right or wrong, but I've been advising them to not go stand in line for however long, packed with a bunch of people who might be sick, but instead to just stay in their home, and then if they have shortness of breath or something gets really bad, then call 911. But before that, they could always check with their primary care physician if they can reach them, but if not, just stay home. So there's a lot of variability in terms of what people are doing. Things that are in the works, I say in the works, it sounds like it either is FDA approved or almost available, but I really have not seen any of these things on the ground or in the chat rooms, but they're talking about self-swabs. The idea with that is that if someone can do their own swabs, they would still go to the hospital. They're not doing it at home. They're still going to the hospital, still waiting in line, but they're handed a swab where they can then do their own test and hand it back to the person who gave them the swab. The benefit of that is that the healthcare worker doesn't have to expose themselves as much to the risk of the virus, because I presume everybody has the virus. So the idea is to protect the personal protective gear and also decrease their exposure. And then in terms of like what we're doing right now, we're using PCR tests. The idea is that it's maybe more relevant to also look at antibody tests at the same time, because let's say that you're testing positive for the virus, you could still test positive for the virus and be recovered. But if you're recovered, especially since this is hitting healthcare workers hard, then, maybe you can go back and still continue to treat the patients. And as I mentioned, diagnosis by symptoms alone, just kind of going through some of these other things quickly. Treatments focuses primarily on critical care. As you might have seen from some of the images on TV, we have shortages in terms of space. So the ICU beds, just regular beds for other patients, isolation rooms. There's problems with staffing. So pretty much, like I said, anesthesiologists are being used in the ICU. People are being redirected all around. Internists are being pulled into the ER. With equipment, there's shortages with the ventilators, of course, the protective gear, medical supplies, medications. We're hearing about shortages. I have heard anecdotally about shortages in terms of even, any kind of sedation to give people when they're being intubated, but I don't know if that's true across the board. And then antiviral therapy, there are about 100 agents that are being looked at. They're under consideration. The ones that have gotten the most attention are hydroxychloroquine, which is also called Plaquenil, which is used usually for lupus, but also can be used as an antimalarial. Chloroquine also can be used as an antimalarial. Some studies have shown that, but again, anecdotal reports, that it seems to be better if it's combined with azithromycin. They say anecdotal, this is sort of like people are doing it because the risk of it seems a little bit low. But there was one study in France where they used it in about 20 patients. Those 20 patients seemed to recover pretty quickly. Within 6 days, they were testing negative for the virus. But we don't know all the characteristics of those folks, if those were going to be some of the people that, didn't show symptoms significantly anyway, or if they were going to be somewhat asymptomatic carriers. Other things that have been looked at, remdesivir, which was studied for Ebola, Kaletra, which was looked at for HIV, or which is used for HIV and is now being looked at for this. Convalescent plasma infusions, that's the idea of taking the antibodies from people who have recovered and giving it to people who are very ill. And then also a company named Regeneron is looking at virus neutralizing antibodies, so to try to stop the virus directly. And then, of course, there's vaccine development studies. One trial is underway in New York. All right, so just generally, Dr. Manchikanti covered a lot of this, so I don't want to go through that at all, but I would say our concerns to some degree with these pain management calls, I didn't think we would be that busy with the telehealth because there's not much we can offer. Physical therapy, they can't do. All these sites are closed. NSAIDs, there's some preliminary evidence they weaken the immune system. The cortisone injections, it's being frowned upon right now, even if the person, I would say frowned upon, but I actually think we would probably get into trouble if we were doing cortisone injections at this time, both because of the steroid and second because it's considered elective in New York. I don't know if that's the case everywhere, but in Manhattan, you know, I think that we would get in trouble for that. Opioids, usually we don't prescribe them without kind of following, we usually don't prescribe them at all, except in certain rare cases. Even then, we're kind of strict in terms of our regulations, but we've kind of loosened that because there's not much else we can do for some of these patients. And I'll just say for us, we're fielding a lot of questions about ACE inhibitors and other stuff. Can you change me to a beta blocker? The reason for this, at least for me, is a lot of our patients can't reach their other physicians at this time. So they've loosened some of the malpractice regulations for anybody kind of treating coronavirus patients. I don't know if it's count because hard to diagnose them with the test formally, but being asked a lot of these types of things that are not necessarily normal pain management questions. And then in terms of, you know, we talked about it a little bit, but kind of balancing, you know, preventing this, keeping everybody indoors. It's really hard on New York to be closed. For our practice, you know, we're losing a fortune just being closed and all the expenses, but it's so chaotic waiting to see, like, if anybody's paying their rent, you know, what's happening with all of this stuff. What are the banks going to do? What's the stimulus package going to be like? But it's none of this is, I don't know if any of you guys have checked, but it's generally not covered by insurance. Pandemics are not covered because it's not a property damage. And then I think I integrated a lot of the stuff from New York City in there. I don't want to go over too much. I'll just say I started writing, Dr. Manchikanti mentioned it, but I started writing this kind of some of these answers for the patients because we were getting bombarded with calls, and I thought if I can create something just standardized to give some of these folks some basic information, that would help them. But then I guess partially to just do something to help in the effort, I started kind of doing it a little more aggressively and then created this handbook called Coronavirus Made Simple. It's not with the latest statistics because obviously it's going to be outdated in terms of the numbers of cases, but it's all the basic information we learned in medical school about viruses. Why is it hard to develop antivirals? What are coronaviruses? You know, what are general antiviral treatments? What does it mean to flatten the curve? So in language for kind of like 8th graders, 9th graders, so that people can get kind of up to speed on the background if they wanted. So that, if you're interested, that's available on Barnes & Noble, Nook, Kobo, Rakuten, Walmart, eBooks, and Apple iBooks. The paper version is on hold because nobody can do all this printing right now with everything else going on. So thank you very much.
Thank you, Devi, for a wonderful presentation. We were going to do all the question answers later, but we already got several questions specifically for you. So first question is, are you asking your staff with any symptoms to stay off work if they cannot get tested?
Yeah, so everything kind of accelerated very quickly with us. So in the beginning, none of the staff had any symptoms. My plan was actually to ask them that. We were more focused on asking the patients. So the staff came up with the idea that we'd ask the patients if they have any symptoms and check that on the phone with them the day before they came, so in the confirmation phone calls. And then when they came in the door, check their temperature and do all this stuff. Now, this was about 2 weeks ago that we were talking about doing that. Things kind of accelerated very quickly after that. So we had the shelter-in-place orders before anything else. So what happened was we were planning to screen the patients. We did that for like a day. The next day, I started feeling kind of anxious because the staff were worried and we were getting all these reports. So I kind of gave half the staff the option to work from home, and then kind of I needed some people to be with me to assist me with the procedures and stuff. So we kind of redid our schedule a little bit that way. I thought that was already extreme, but then in no time we had it shelter in place. So there's no procedures going on in our site now. So everybody is working from home. And the only person that's going to the office is me. And that's mainly because I don't go every day. I go when there's a problem. That's mainly because it's not a server, but we rely on some of the equipment that's in the office for everybody else to be able to work virtually. So I have to go in and check on that stuff periodically.
Okay, your next question is, we will be going to Vanila in a few seconds. If a person tests negative, are you repeating the test 24 hours later because of the high false positive rates?
Yeah, for me, I actually haven't ordered any tests for anybody because the patients who are coming back coronavirus positive, they didn't have symptoms when they came to see me, or if they did, they didn't tell me. They were more calling me to alert me that they might have exposed me or my staff. So we didn't order those tests. And then now that the patients are asking us about ordering tests, you know, I kind of look at it, the ones that have called are really more on the vulnerable side to begin with. They're older, they have multiple medical problems, that's why they have pain. So I haven't ordered any tests because even if I did, even if I gave them a prescription, in order to go get it, there's all these lines and areas where people are packed together. And I just think these patients, let's say they were negative, they could come back with a negative test and get exposed while waiting in those lines. So what's the point? And then second, if they do have coronavirus, I don't really want them going out and exposing all these other people. So I've kind of advised them to stay home, maybe call their primary care if something worsens, but otherwise just be prepared to call 911, have some kind of buddy system if they live alone, but to kind of go by symptoms alone more so than the test.
Okay, thank you, Devi. Now, it is Vanila Singh. She just retired as Chief Medical Officer at CMS. Now she returned to her old job as professor at Stanford University. She is an active practitioner. She has been in advocacy as well as helping pain physicians for years. Here is Vanila.
Thank you, Dr. Manchikanti. And actually, I was Chief Medical Officer at Health and Human Services, and CMS is one part of it. So I appreciate that. Yeah, no problem. No. It's all important, all part of it. CMS, FDA, NIH. We all know Dr. Fauci is within NIH at NIAID. And I also want to say the Surgeon General was, part of my team. We used to answer to Admiral Giroir, who some of you may have seen on the White House press briefings. He's been actually the one who's really ramped up the testing that had gone from about 2 weeks ago. They were predicting 1 to 4 million, and they got 10 million tests out there. And it has been challenging only in that in the beginning it was only CDC that wanted the test, and because they were trying to ensure that they, I think some of it was also validation of false positives and false negatives, which both have ramifications, especially false negatives. But they ramped it up to, in fact, over 10 million tests. My understanding is, as of 2 days ago, they were reporting that what South Korea did, which a younger population of 51 million people in their country, they were able to do about 290,000 tests. The U.S., and they did that in over 8 weeks. We surpassed that in 8 days. So it was slow going, but part of it is the infrastructure, just like Dr. Davie was just mentioning. And New York is unique in that having a drive-through testing option is probably very limited unless you're in the suburbs. But in Manhattan, it probably poses a greater public health issue, which I think I appreciate her thinking on that. The over here in San Francisco, which is really actually had begun the shelter in before anybody, we noted immediately that was done with shelter in with our schools closing. My children are both home, and they've been doing e-learning online through Zoom and other measures, as well as the grocery stores keeping the food supply there, really to keep a sense of calm and the social distancing. But, I think we all have heard and know about much of this. I just wanted to make a couple comments to sort of round out New York being, of course, the big epicenter, and our thoughts and prayers are there, but actually really emphasizing to all our patients and communities and colleagues, the big concerns, of course, are keeping the social distancing, but from the healthcare perspective, the healthcare workers, the big issue being the personal protective equipment, which we know that a lot of private companies are stepping up. Apple just donated $10 million. I believe there are companies on your side of the coast, Dr. Davie, like in New Jersey, they found $150,000. A lot of it came from the emergency preparedness that came post 9/11, where they went into their stockpiles and have found N95s and other surgical masks and stuff. And then we know about the repurposing of the ventilators that are going on. I think they just asked GM through the Defense Protection Act to go ahead and turn around and start to make the ventilators. But, the big news is like Tesla is doing it and many other folks. And the real question is, how do you get everything out there to the folks? And in terms of pain management, just here at Stanford, we began screening for COVID potential symptoms 2 weeks ago. So before my patients and clinic procedures, we had made phone calls to every single person, and we're already instituting that. And anyone who had any symptoms that were suggestive of cold, cough, flu, or anything else really, myalgias or whatnot, we were asked to stay home. And we have also instituted virtual visits. So, for example, next week, my clinic procedures, we're converting those patients to virtual visits, which are important in the sense of course, the non-interventional procedures. What do you do in the interim? Well, of course, there's medications, opioids and non-opioids. We've also been amping up the behavioral health portion to offer it both to Stanford faculty as well as our patients. We used to do that before, but now there's video resources and there's a lot of material that our clinic at Stanford Pain already did. So those have been, ensuring that we're able to get them to have means to help with the potential mental health concerns, both with their usual chronic pain issues, but also with the current COVID crisis. And then one other point I'll make is my husband's chief of staff at his hospital is about 1,000 doctors. And you can imagine it is, a huge effort. It is in Santa Clara County, which is the #1 county in the Bay Area, where there is, an Asian population. So initially it came here, but, they are also doing much in the way of compassionate use of different medications. They are keeping ahead in terms of their ventilators and their stockpiles. And I just might add to everybody that FEMA keeps emphasizing that when we hear about people, concerned about not getting the PPEs or ventilators and stuff, they have local coordination folks as well as the public health folks. You're supposed to actually let them know, because the big priority right now is to get the equipment out to those spots that need it. So I think yesterday, Governor Cuomo, they got like 4,000 ventilators out of the stockpile, plus the Navy ship hospital is supposed to be there. As well as in LA, they got the Navy ship hospital. Both of those Navy ships will be seeing non-COVID patients to free up resources. So that's kind of just a status update here. But what I think I really wanted to focus on, that Dr. Manchikanti correctly pointed out, was what can HHS do and what is HHS doing? And so there's a lot of amazing, novel, innovative medical treatments, both in the biopharma, biotech, medical device arena, that we know can play a role, if not in the vaccine arena, which is, going to be very specific to, say, Moderna and their efforts with the new vaccine trial over there. This can be therapeutic attenuation of moderate to severe symptoms, or people who are positive COVID but can prevent prophylactically the development of symptoms, all which would help with decreasing the transmission. And there are ways for any of you, because this is really a call to duty if you think about both in our knowledge and our care and, of course, our oath to help our patients, in going into medicalcountermeasures.gov. And that is a website that within HHS, BARDA, the biomedical, the research innovation arm, if you will. So NIH, of course, does the double-blind, randomized controlled trials that we all know go across the nation. But this is where innovation can also be found, and they really created this platform to be able to allow folks like us and our colleagues to submit requests for meetings in terms of development of countermeasures against this COVID-19. And they are actually looking at it from the infectious disease, but of course from the technology perspective and others. So what I wanted to share was they have this really, in terms of a request for meeting, which will likely, of course, be over phone. It's in creating a meeting request regarding vaccine-related products and services, create a meeting request regarding diagnostic-related products and services, therapeutic, creating meeting requests regarding therapeutic-related products and services, and others. Because we know that I just heard today that there's a company that has sort of the UV light equivalent, if you will, in terms of going to public places and killing the virus and other infectious disease agents, just like, say, a disinfectant wipe might, but it's able to do it on larger contact surfaces. So there's a lot of innovation in areas that we're not even thinking about that might help decrease the spread. In terms of diagnostic tests, Dr. Davie already mentioned this, but we know that having the ability for the person to do their own nasal swab not only allows for, they can't do it at home, they still have to go to a drive-through or place, but it saves personal protective equipment, and it just allows for a quicker, easier means to do diagnostic testing. The FDA has cut a tremendous amount of red tape and bureaucracy, and the red tape and bureaucracy are like gut checking when you're in this realm at HHS. It is incredible how the processes work. A lot of that has to do with when something comes out from CDC, FDA, there's a lot of stock that's put into that. People believe it and follow it. So they have to be super careful. But of course, in this type of pandemic, of course, affecting the United States, they are trying to cut those actual processes, the red tape, to advance rapidly the consideration. And, there are things, for example, the ibuprofen issue of what the reports coming out that perhaps it may have been harmful in terms of increasing the severity of symptoms. The FDA went online on March 19th, and so far they're not advising that it's against it, but they did say that they're looking at it. And all of these are going to require clinical trials the same way with IV vitamin C that is being given in New York City at some of the ICU pulmonary care units. They are doing that in 4 doses a day, far exceeds what the usual recommendation would be, but there is some consideration of how ascorbic acid might actually have a mechanism in terms of affecting the development of inflammation from the neutrophils that infiltrate the lungs. But so I'm just giving you examples of really common things that maybe we know, because as pain physicians, we know that in the immune system and the inflammatory response plays a huge role. And so unlike what most people would believe, we all have probably much greater insight into both the perioperative development, but of course in the long-term chronic pain development of inflammation and how a role it can play. And I've had folks from around the country reach out to me with their concepts and ideas, from technology platforms to even peripheral nerve stimulators or stem cell treatment, etc. All kinds of things that they really believe over their years of research can actually probably advance and help attenuate the response. And I'm saying a lot of this rather quickly because I have to jump back on another call that is related again to the COVID virus. But I also want to inform everyone, I think you all know because you're all experts in this realm, but the DEA has also relaxed its stance on the renewal of prescription opioids, which are going to be in some ways, along with some other non-opioid medications, some of the go-to medicines in the interim, while we are unable to go to elective procedures, and they are able to do that through telemedicine. And CMS has also, of course, allowed for a rapid advancement in the telemedicine arena to help assist all doctors, really because of the obviously the challenging time in order to see their doctors, but specifically for us, when you think about controlled substances, it is, you know, a very challenging time that folks who are also not in the COVID arena, it's not like their urgent issues are, you know, able to be put off indefinitely. You know, we hope to see this take a turn, but I think this may be the time to be able to document and help in terms of ensuring that the patients, for other reasons, don't end up with poor outcomes. And these are our patients that we know will very much need it. In many ways, they feel it's urgent to have these types, the procedures, the interventional procedures that are performed, you know, whether it's quarterly or annually or even daily, weekly, if it's trigger points or something like that. But in order to ensure that that outcome is not worsened, to keep those measures in mind. That's really from the FDA, CMS, NIH, NIAID. They're the ones who are sponsoring much of the rapid clinical trials. If anyone is looking at those, there are many places, including some of the larger medical centers like Duke or University of Minnesota actually has a couple of these where they are looking at the hydroxychloroquine plus azithromycin for positive COVID patients to either reverse symptoms or prevent symptoms. But also losartan is another one that's well-known antihypertensive that's being looked at from very interesting mechanisms, also at University of Minnesota, to reverse either prevent multi-organ failure or to prevent symptoms and hospitalization. So I just urge all of you, I know that there's a huge amount of resources being put into this, and whether you are in some interesting realm where you have patients and you have some ability, the resources are there. There is a massive backlog, but they have created this new platform called medicalcountermeasures.gov to allow for a request for a watch meeting. People are working around the clock is that, and you know, having worked with many of those folks, you know, I can tell you that it is, you know, where the Secretary's Operations Command at HHS is where, you know, the prior public health issues, whether it was the flu, but certainly during the hurricanes and all, they were keeping track of the data. And the U.S. Public Health Commission is also out there along with CDC. One other thing that I wanted to mention was the CDC has their influenza platform where they track influenza cases. They're converting that now to COVID-19. So if you have the time and inclination to go to that, they want to utilize that as a means to also track data. And of course, you know, us being all in physicians in healthcare, we certainly have a means to help with tracking the patterns and the data and where the resources should go. So I wanted to kind of give a broad overview, happy to answer questions or give some resources afterwards, and can take a few questions now.
Thank you, Vanila. We will answer all the questions at the end, I think. So again, thank
Perfect.
you for this, and for all the members who are attending the seminar. Vanila headed the Best Practices in Pain Management Task Force and came up with the best document in pain management, which is only about 500 pages. Very nice reading. And it took her only 6 months, and she lost half the hair and everything else. But
well, leading a task force.
Right. So we will, that is the best document we can have. Everybody, it is a very good reference document if you want to go and look at it. And anytime insurance companies question you, you can produce that document.
Cite it.
Yeah,
Actually,
go ahead.
Actually, if you don't mind, Dr. Manchikanti, thank you for reminding me, because the audience is one and the same. One of the purposes of that task force, it was congressionally mandated report, is to not only bring it all together, make it educational for a layperson, but also a scientist to appreciate it. But it's really intended to not only have the federal government start instituting or implementing some of these things, but just like Dr. Manchikanti was saying, it's really intended also for you to utilize it as a resource. It's 500 scholarly documents. Of course, we cite ASIPP all over, because how could you not, with so much great data and ASIPP being ahead of the curve. But it brought together all the pain organizations, but as also AMA, the AAOS and American College of Surgeons, the acupuncturists, the social workers, the pain psychologists, every organization you can imagine, up to 150,000. Since you may have some time, I would definitely urge you to go through it and find what part of that it helps support your efforts, and to cite it, because it was an interagency task force with DOD and VA, with not only pain doctors, but uniquely so primary care, surgical, mental health, addiction, Veteran Service Organization, pain, and of course the DOD, the VA, and FDA, CDC. So everybody was on that task force, and so it really was intended to not just be a one-time document that is there, but rather to help your efforts, whether you're research or you're clinical and you're putting out something. So Dr. Manchikanti, thank you for telling me that. I've been so in the COVID mode that, all this, what we actually know will be, of course, our calling after all this to continue to help our patients. That's really intended to help all of you.
Okay, thank you. That is great summary. Now, it's going to be Amol Soin, my dear friend, and first Executive Vice President, and he will be the President-elect on April 2nd. He's a researcher, physician, philanthropist. Wherever you go to a different city, you see their name somewhere. And he has done a lot of work on this. He has a business degree. He is in the forefront of this issue. So he's going to talk about Ohio, opioid prescribing, etc. And after that, he will control this seminar until the end. And at the end, we will both join again together and answer all your questions, all of us. Okay, Amol.
Yes, thank you, Dr. Manchikanti, and greetings, everyone from Dayton, Ohio. Thanks for taking time to be on this call and webinar. A lot of the questions that we're getting at ASIPP is about whether or not you should be doing elective procedures, should you still be doing injections, epidurals, and whatnot. And I'm going to, for this first part, I'm going to use the example and statistics from Ohio to explain why that's not a good idea. At the end of the day, ultimately, you are responsible for what you do in your practice. What I'm saying is just my opinion and perhaps some advice, but at the end of the day, you're ultimately responsible, and you should, use your best practice as well as the regulations locally. But let's look at Ohio, right? So the reason why is you can boil down to Ohio because demographically, Ohio basically represents the country. Big cities, small cities, all racial demographics. There's really rural areas, really urban areas. And we can use that to model disease spread. And we can also use the model to test the effectiveness of social distancing measures. And you can see here, this is our state as of yesterday, because I had to upload these slides yesterday. It's not current for today. And you can see the dark red areas are the areas where we've had significant spread of the virus, which is basically Cleveland, a big population center, Columbus in the middle, and then Cincinnati in the southwest. And a lot of the map hasn't really filled in. My particular county, Greene County, only has 3 cases, right? So you could wonder how significant is all of this until you look at this chart right here, right? And here's a growth chart, and you see this exponential growth from just March 10th to March 25th. Now, granted, I admit there's been increased testing, but you can also argue that there's also been increased community spread through this time period. And you can see here the daily increase in Ohio confirmed cases. Now, on March 13th, it's when we really got a lot of tests back, when we really started testing aggressively, which explains that ramp rate. But here you see continuous spread of the disease, and we've sort of leveled off at about a 25 to 30% increase in cases. But these numbers compound day after day. And if you look at here at the Ohio map, kind of filling in from March 13th to March 24th, then I suspect the map of the United States will fill in, and eventually I would suspect that all this green would fill in as well. Ohio was extremely conservative in how we managed things, and there's things that Ohio has done well. Social distancing, for example, right? Ohio was the first state to close all their schools. Despite the fact that we didn't have a lot of cases, we have a governor that was very progressive and listened to physicians. It was one of the first states to shut down businesses, the first to really push all this lockdown type measures. State leadership and our governor really listens to doctors, and they do daily press briefings. And honestly, the people who talk the most during the press briefing is a physician. The State Medical Board of Ohio is a really strong leader with daily emails, constant updates on their website. But despite all of this, we're seeing such an increase in cases, right? And yesterday they were saying that by May 1st, at that point, even with all the social distancing, as progressive as Ohio has been compared to other surrounding states, and when you look at Ohio compared to other surrounding states, our incidence is lower. We expect that by May 1st, as many as 6,000 people per day may be testing positive for the disease, at which point we hope that the curve will start to flatten and then start to decrease. But if that occurs, even in a state like ours, where we've been so progressive, I mean, the system could get overwhelmed, ERs, emergency rooms, ICUs, and you can see here on this slide where we're at right now, we have 704 cases, and 11% of them are in the ICU, and 15% of them are currently hospitalized. But the big issue the concern is that this exponential growth is going to place a strain on the system, right? So if you're thinking about doing elective cases and using PPE that could be used elsewhere, that could pose a problem downstream. I mean, right now we haven't felt a lot. There's a lot of questions about finance, which I'm going to get to, but honestly, right now we haven't felt a lot of financial issues or harms, because the way billing works in healthcare, it's about a 4 to 6 week run as far as collections go. So we're still collecting from procedures we've done before. We're all going to feel a lot of pain in June or July, and that's when you're going to have to start making decisions. So we're going to have to start preparing for that now, which is what I'm going to talk about in about 10 minutes. When it comes to your patient, what should you do with them? It's funny because we did so much work in avoiding opioids, but in this short time frame, I mean, I see questions on this board popping up. What should we do if someone's in really severe pain? What should we do if they can't function, et cetera? Maybe consider trying an opioid to see if that would be helpful. And again, this is just my opinion and my advice, but I think it's going to be challenging to use some of your PPEs. It varies regionally, right? Some states are aggressive and others aren't in terms of what you can do with elective cases. And I think globally across the country, you can see that a lot of areas are not allowing elective cases. Your Department of Health can provide you guidance, but some areas are a lot more restrictive than others. I just saw this some information from Texas that they were saying that physicians have a duty to disclose if one of their colleagues is doing elective procedures, and if they find that out, you can get a reprimand from the board, you can get a fine of $1,000, and even jail time up to 180 days. So they're taking this very seriously. Other states are not, right? So it's something to consider, because I know that there's a lot of questions and a lot of volume of questions about wanting to do procedures. So keep that in mind. I'm going to turn over to Dr. Buenaventura, who's going to talk about some telemedicine options. And then after that, we're going to talk about more of the business and economic impacts to your practice.
Thank you, Amol. Thanks for having me. Welcome to everybody who's listening to this. I see we're up to about 800 people now. That's great. Just to background myself, I'm an anesthesiologist, pain management physician in Dayton, Ohio. Just have a solo private practice. And like everybody else, I was following this coronavirus event as it was happening, and started thinking about what can we do to get ready when things get really bad. And I saw people were talking about telemedicine. I asked my staff members to help with getting things optimized and ready to go when and if a lockdown happened. And fortunately, they did. My office manager, Cheryl Spang and medical assistant Amanda Hemrick were very helpful in getting this going. And let's move along here. So, importance of telemedicine. Why now? So, telemedicine's been in existence. Predominantly, it was mostly to bring medical services to rural areas, or also to bring specialists into areas where there might be a shortage. Think mental health. But now with this public health emergency that you've heard about for the past hour, I won't go over that. But now the importance of telemedicine has come to the forefront, really, to just keep people away from each other. We don't want people driving needlessly to their doctors to get a prescription for a medication or just to get a follow-up on a procedure. So if we can do those via telemedicine or telehealth, that's much better, safer for them, safer for us. It can prevent infections from spreading and prevent you and your patients from getting sick. So you hear about this waiver. The 1135 waiver is a waiver that's been in existence, and it was invoked last week, March 3rd, 17. Essentially, when a president declares a disaster or emergency, the Secretary of Health is authorized to take certain actions to ensure that sufficient healthcare items and services are available to meet the needs of the individuals. This was, again, invoked earlier or last week, about 10 days ago, and you can see there's a link to that. In it, they spent a good bit talking about telehealth. So essentially, they talked about 3 different types of telehealth visits, and we'll go over them over the next 3 or 4 slides. Essentially, when we talk about telehealth visit, think of audio and visual communication. So this would be telemedicine, telehealth. This is for a variety of providers, not just physicians and PAs, but can be used for clinical psychologists, social workers. There should be a pre-existing relationship before this goes, but of course in this scenario, they're allowing or understanding that new patient visits can be done this way. There will be no audits done for telemedicine and telehealth visits through June, which can allow for this to go, and of course this will go on until the waiver is released. Virtual check-in. A virtual check-in is essentially a telephone visit. So if you're talking to the patient by telephone with no video, this will be considered a virtual check-in or a telephone visit. It's coded differently and paid much less than a telehealth visit. E-visits are electronic communications through a patient portal. Think of an email or text. It's charged as total contact time over a 7-day period. So if the patient is sending you several texts throughout the week and you spend more than 5 minutes, you can charge a certain level. If you spend more than 20 minutes, you can charge another level. In both of these scenarios, any communication should not be related to a prior visit within the last 7 days. Also, essentially with these visits, there should be some kind of recording going on. That also will be waived during the public health emergency. So, prerequisites for a telehealth encounter. You should verify you are speaking with the patient and document as such in the record. The patient must give consent to and initiate the telehealth encounter. This can be just a line in the note. Service must be medically reasonable and necessary. The patient should initiate the call, and it should be, again, something that's medically necessary. You shouldn't just call the patient and talk to them and see how they're doing and then charge them for that call. The service must be performed by a physician or a qualified healthcare professional. The time spent in the discussion should be documented, and it should be at least 5 minutes because all of these codes expect you to spend at least 5 minutes. There's no code for anything less than 5 minutes. And you should document the means of service, again, whether it was a portal visit or a telephone visit or a telemedicine visit. So coding as per CMS guidance, this is straight off their website. Medicare telehealth visit. These visits are considered the same as in-person visits and are paid at the same rate as regular in-person visits. So these would be your standard E&M codes, 99213, and so on. A virtual check-in is when you're using a telephone. The code is G2012. And then for patient portal visits, again, over a 7-day period, if you spent 5 to 10 minutes going over those emails and texts and messages in MyChart, you can charge $99421, and if it's over 20 minutes, it's 23, and in between 11 to 20 minutes, 22. There's no recommendations for modifiers for CMS on these codes. There essentially is a change to site of service, right? You're no longer doing it in your office, ASC, or a hospital. You're doing telemedicine. So essentially, you've got to change that to telemedicine visit, home, wherever your location is. Rules regarding HIPAA compliance of telemedicine encounters are waived for the public health emergency. So the HIPAA compliance relates to the telemedicine software you're using, whether it's HIPAA compliant or not. You know, prior to this public health emergency, there were only a few expensive vendors, or mostly expensive, not free telemedicine vendors. And again, it was geared towards serving people in rural areas or telehealth. So those are HIPAA compliant. They're more rigorous systems. And so those, you know, the vendors charge you for that. So now you're allowed to use any kind of platform, including FaceTime and such. So that allows you to use these others and not have to worry about HIPAA compliance. So this table here is straight off the CMS website, and it's important to pay attention to this. I went over it already, but look at the Medicare telehealth visits. And if you go all the way over to the right, it says there, to the extent of this public health emergency, the waiver requires established relationship. HHS will not conduct audits. So they're referring more to whether you have an established relationship with the patient and as far as HIPAA compliance. So it's specifically to this telemedicine consults and the audiovisual, but it still states in there that it's expected that you're using some kind of audiovisual communication. The coding will be there as mentioned, 99201 through 99215 for office and outpatient visits. The other ones relate to other types of situations or non-physician providers. And then you can see for virtual check-in and e-visits. Again, it says those are for established patients and should be such. So commercial insurance, I've seen some questions about this already. I'm just going to tell you have to do your own legwork. You know, we're talking to over 800 people here today all over the country. Commercial insurance companies all have different policies based by states and whoever they've contracted with. I will say that the major insurers, all of them, you know, have contacted us in Ohio and sent out emails expressing their understanding of this public health emergency and willingness to work with us. You know, they're making a good faith effort to pay for the services, and they understand and respect what we're going through and in these trying times. I haven't seen any one of them say they're not paying for that. That includes Anthem, UHC, Aetna, Cigna, Medical Mutual. And that's for Ohio. I can't speak for those insurances or others in California, Florida, New York. I'm going to tell you to go ahead and research, do your own legwork on that one. But they will be adopting policies allowing these types of visits. There may be some variations with modifiers and such, so pay attention to that as far as commercial insurance and modifiers. And again, it's going to be up to you to look at that. So as I said, in my small office, we adopted telemedicine, and we did it pretty quickly. You know, we started looking at different platforms. I also want to point out we do have a poll going, so please take a look at that poll. Click on the poll link and then answer it. It relates to questions as far as what people are using platforms. So basically, if you're working for a large university health system, you're just going to do what the organization has suggested in terms of platforms they're using. But for small groups, solo private practitioners, you know, with the HIPAA waiver, you can use whatever you want through June. Just be smart about it. So we looked at several ones. We talked about DoxyMe, Google Duo, FaceTime. FaceTime, you need to remember, it's only for iPhones. So half your patient population is using Androids. FaceTime is not going to be a good one to use. And in fact, when we contacted some of our patients and told them that we're using Google Duo, a lot of these patients said, yeah, well, I'm already using that because I have an Android and we're using Google Duo to talk amongst our family members. So that's what we use. We decided to go with Google Duo. over some of the other options such as DoxyMe and FaceTime and Skype and such. So telemedicine using Google Duo and ER from the home. So we've already done this in stages the past week, and we were able to do visits where I was essentially in my bedroom on the computer with a iPad using Google Duo and the electronic medical record on my PC computer, and I can log into Epic on my computer. I've got Google Duo next to me. My staffer has called the patient and put her on Google Duo on screen share, and we're all talking to each other, carrying out the conversation. The staffer is listening to the conversation and transcribing as I'm talking. After the visit is finished, I can do the physical exam and the plan. For virtual check-in, my staffer will use her own cell phone. We've basically routed the phones from the office to her cell phone, and when it's time for one of these calls, she'll use *67 to, block the caller ID, and then she contacts the patient and then calls me, and then again, we're all on the phone. I can talk. She's at her house on her computer. I'm at my house on my computer, and we're talking to the patient, conducting the conversation. Let's see here. Physical exam by visual inspection. So with the audio-visual, you can do a physical exam. Just by looking at the patient, you can see what condition they're in, or if they appear ill or sick, if they're breathing fast, if they have a rash. I have the patient set their phone down or their iPad down, and then I have them do a musculoskeletal exam. I'll have them walk across the room. I can have them tiptoe across the room. Have them bend at the waist to assess their range of motion. I have them sit down in a chair and straighten out their legs as if we're doing a straight leg raising test. I'll have them cross their legs for a Patrick's test. So you can do all of these things with the audio-visual and bill for it legitimately. Last detail. So essentially, you're going to turn your office, essentially close down your office. You could, and that's what we've essentially have done. We've changed procedures where the mail is delivered to my office manager. So my checks are going to go to my office manager. She does the billing. She can see what checks came in, deposit them. She can scan them electronically with the bank. She can do the EOBs and the billing. My other staff manager has the phone with the phone lines being sent to her, or the phone calls being routed to her. She takes the phone calls during the day, and she inputs the messages through her computer at home into the EMR, and then I can check it at night or during the workday and get back to her. We put signs on the door essentially stating that we'll be on irregular hours and to call the office to speak to someone, that someone is answering the phones, and we've left a message for mail deliveries to be left. And of course, we are checking the office daily. Somebody runs by to check on things. And here's a picture of me on the old iPad with Google Duo going, and you can see the screen, the computer off to the far right. I cropped it to block out the name. But that was me just a couple days ago working in my bedroom. And with that, I'm done, and I'll turn it over back to Amol.
Thank you. Amol is going to come back in a second. This is Laxmaiah Manchikanti. Our attendance right now is 996. So, Rick, you really underestimated it. One of the questions, I already got several messages here asking the difference between telephone, audio, video. You can just do the telephone, at least for Medicare. We can do for all of them, actually. We are talking to the senators and members of the Congress, and they were all surprised that the private insurers are objecting to this. So their solution was that the president has to issue an executive order, then that should be resolved. So that we are working on that. Hopefully we'll be successful. When you are using some of these softwares, you need to remember that they're going to write down your time. Right now, we are going to use regular codes. It is not time-based. It is based on history, medical necessity, and indications and discussion, the only two components. Whereas if you put on a time factor, if you don't spend 15 minutes on there, you don't get level 3 visit. It will be very difficult to justify that. these are the things we need to keep in mind when we go for telemedicine. Right now, the simplest thing is just to go on the phone. And as Rick said, a lot of people don't have these connections, and they have WhatsApp, but nobody knows how reliable that is. And one of my friends from St. Louis is having problems just having them regular phones. He says that half of his patients spend all their available minutes during their first week, and after that they don't have anything. I'm sure many of us are facing that situation. Now, thank you, and back to Amol.
Yes, thank you, everyone, and I appreciate everyone listening in for so long. And judging by the volume of questions, there's going to be a lot of other stuff we need to break out more on regarding telemedicine and also business and economic impacts and how to survive in all of this, which we'll probably make up in future webinars. Also, for all of the state presidents of your various SIPP organizations, we actually encourage you to consider having your own teleconferences and your own webinars, and we can help you with that at ASIPP. If you email Melinda Martin, we can kind of help you, guide you through that process, because one of the great things about ASIPP is their reach in all 50 states, and because there's so much regional variability in laws and rules, I think that would be helpful for your members. Honestly, guys, I can tell you in about a month and a half or 6 weeks, we're all going to be experiencing a lot of pain, and I mean that pun intended, because things are going to change for us in many ways. First of all, business and economically, what's going to happen is all of the drop in volume that we're noticing over the last 2 weeks, the drop in procedures, the decrease in E&M visits, and what you're going to start to see over this next month as we lock down further, it will really start to impact you. And you're going to have some difficult decisions to make financially and otherwise. And the second area of pain we're going to experience is we're going to see a continued surge of cases. And right now, a lot of people may not have a lot of awareness because where you live, there may not be a lot of cases yet, but we expect those to grow. We're trying to buy time with all the social distancing and stuff, right? Because there really isn't a treatment or cure for this novel disease. And our modeling in Ohio said that let's assume we don't have a cure or vaccine. Within 24 months, 70% of the population will have contracted the virus. Right? That's pretty impactful. So it's important to keep that in mind as you make your decisions going forward. So regarding your business, right, there's a lot of questions that are popping up on what you're supposed to do. How are you going to stay solvent? How are you going to handle your payroll? And there's a lot of stuff that's come out over the last, literally the last day and today regarding the stimulus package, right? So how do you navigate your national SBA loan options and what's out there are some important questions. And there was a disaster loan program that was initially done by President Trump, and that's done nationally through the SBA. And there are ways that you can find that information pretty easily. I mean, this is a screenshot of my cell phone typing in disaster loan SBA, and you can see how you can apply for a disaster loan. And there's been some changes to that with this new CARES Act. Now, individuals that are sole proprietors can apply for a disaster loan, whereas before you couldn't. And that affects people that are 1099 independent contractors, maybe people that do a lot of locums, et cetera. And then, private nonprofits and some tribal businesses were added on too. You no longer require a personal guarantee or on advances of loans under $200,000. And there's another thing that's happened recently, that the COVID-19, because of that particular disaster loan, you can request an advance of up to $10,000 on that loan, and the SBA is supposed to distribute that advance within 3 days. If the application for that particular loan is denied, you're not required to pay back that $10,000. And one interesting thing that I've seen is there's a lot of lawyers out there that are offering services to help navigate through this loan process, and they're asking for a $10,000 retainer, and I wonder if it came from that particular advance. Something to think about. But there's another thing that has come out recently with the CARES Act, and that is this newly enacted Paycheck Protection Program. So a lot of people are wondering, well, how do we make payroll, and what are we supposed to do? And there's a couple options, right? One option is you can file claims for unemployment, and that varies from state to state because unemployment is typically a statewide program. And this is just a screenshot from my cell phone, typing in unemployment in Ohio, and you can click there and file weekly claims for your employees. And there's some limitations on what Ohio in particular has to offer, and there's also some limitations in other states as well, so it's state specific. So for example, Ohio, there's a maximum benefit of $533 a day, up to a little bit over of $113,000 a year or something like that. But there has been some changes with the CARES Act where the federal government is also offering some subsidies to unemployment, enhancing unemployment insurance and beefing that up. So when you're worried about payroll, like a lot of private practices are, or even a lot of hospital networks are, you basically have two pathways, well, three pathways you can consider. One is you can retain everyone and keep paying the salaries, which is going to get financially difficult. Two, you could, lay your employees off and have them file weekly claims with the various unemployment options from the state and what other subsidies you get from the federal government. And the third new one is there has been a new loan that came out through the stimulus package, this newly enacted Paycheck Payment Program. And the new program will be offering 100% SBA guarantee through December 31st to lenders, after which the guarantee percentage, decreases over time. And you need to apply for this particular loan on or before June 30th, 2020, with the lending institution authorized to do this type of loan. And what that basically means is to apply for this type of loan, you actually have to go to your bank, because a lot of what happens is the federal government is actually guaranteeing this loan, but the loan is actually administered by a local bank. So if you're looking to get one of these types of loans for your Paycheck Protection Program, which is a good loan, and I'll tell you why in a second, you should actually contact your local bank, and it might be good to contact a lawyer. Borrowers are required to provide a good faith certification that the loan is necessary due to the economic conditions brought on because of COVID-19, and that the borrower will use the funds to retain workers, maintain payroll, pay utilities, lease or mortgage payments. The loan amount has a $10 million maximum, which is double the customary SBA 7A loan maximum through December 31st, 2020. It will have a maximum interest rate of 4%. The lender will determine the loan amount, and it's based upon a multiplier of 2.5 times your payroll. So your payroll was, last year you multiply that by 2.5 times, and that's, sort of the amount of the loan. Borrower payments for this loan will be deferred for a minimum of 6 months and a maximum of 12 months. The loan amount is tied to a formula that's based upon payroll costs that are incurred, and there are specific things that the loan can be used for. Payroll support, insurance premiums, I mentioned mortgage and rent, and utility payments. Any portion of the loan not used for those approved forgiveness purposes I'm going to mention should be transitioned to a 10-year term loan. Now, one of the cool things about this particular employee or Paycheck Protection Program is that there's a forgiveness of the loan. And that's huge, right? And the borrower will be eligible for loan forgiveness related to a Paycheck Protection Payment loan in the amount equal to 8 weeks of their payroll costs. So if you follow those guidelines, it changes from a loan to a grant. And that could be quite impactful for you in terms of maintaining your costs and maintaining your employees on payroll for you. We're lucky in Ohio. We have this law firm named Taft, which is named after the president, William Howard Taft, I believe. But they've been providing OSIPP members daily emails, and one of them was all about how to take advantage of this loan forgiveness program. So it's really helpful. But the payroll costs are limited in compensation for a single employee. It can be no more than $100,000 in wages. Right. So those of you who actually, if you own your own practice and you pay yourself over that, I mean, the cost that's forgiven is only up to $100,000, and the amount of forgiveness cannot exceed the principal loan amount. The amount of loan forgiveness will be reduced proportionally by any reduction in the borrower's workforce. So a reduction of more than 25% of the employee's prior year's compensation is used as a measuring stick. And the other measuring stick is a comparison of the borrower's numbers of employees last year. If a borrower already had laid off employees due to COVID-19, employers are encouraged to rehire them and not being penalized for having a reduced payroll at the beginning of the covered period. So it's just something to think about. You know, we're going to have some really difficult financial decisions to make. You're going to have to make a decision on whether or not you want to be part of this forgivable loan by June 30th, 2020. And as I mentioned, a lot of us may not be feeling financial strain right now, but it is probably going to come for all of us. So you should try to get ahead of it if you can. And if the loan, if you can really qualify for one of these loans that's forgivable, it basically becomes a grant. It ends up being free money to keep you afloat, so to speak. So it'd be important to, you know, talk to your banker, accountant, potentially even a lawyer, just to make sure you can qualify for it, and do that. You can see here the stimulus package that was done. You know, there's some notes here in the slide deck, and I know we're running out of time, so I you know, don't want to go over all of these things. You know, we could potentially make the slide deck available, or I can work on some FAQ documents for some of the questions that were answered. But what I was mentioning about the payroll and the Small Business Administration stuff, that applies for employees with 500, entities with 500 or less employees. So if you work for a hospital or large academic institution, that doesn't actually help you, right? Well, another aspect of the bill that was just passed is the package includes $100 billion in assistance for hospitals and other health systems across the nation. The goal of this package, in some extent, to stimulate the economy, but to the other extent is to help small businesses like private physician practices and prevent hospitals from becoming insolvent. Schumer also said the plan offers billions more for critical investments into personnel and protective equipment for healthcare workers. And lawmakers also agreed to increase Medicare payment to all hospitals and providers, according to Chuck Schumer. But we'll actually see what happens with that. As we move on, and we'll have another webinar in the future, I'd like to spend time at that point in time going over what we all need to do to stay solvent as business entities in order to continue practicing medicine the way we are. In the meantime, I think it's important to stay vigilant with your local health authorities in trying to follow the rules. And I know that there could be extenuating circumstances where patients, the risk to benefit ratio would be in favor of doing a procedure on a patient. And I just want to mention briefly kind of what's happening in our local area, because Ohio has placed a restriction on elective procedures. I have an ambulatory surgery center, and that closed about 2 weeks ago. It's no longer open. We're not doing any cases there at all. And actually, I donated some PPE to my local hospital institution. Our local hospital institution are allowing pain management cases, but they created a scoring rubric, and basically there's different items and questions on a checklist, and you have to score high enough to go to this physician panel review, and from there it goes to a physician panel, which is made up of multiple different physicians from different specialties, and they determine whether or not this meets the criteria for a procedure that would ordinarily be considered to be elective to actually be done at our institution. And so far, the only one that I've seen that's passed that particular thing was a malfunctioning intrathecal pain pump that was requiring some significant intervention. But again, that's just what we're doing here locally. I mean, obviously, that's going to vary from place to place. But the fact that they have such a defined system in place, I believe, does provide them some protection in terms of doing cases that would ordinarily be elective. But at the end of the day, you're responsible for these types of decisions and what you want to do to advocate for your patients and society as a whole. If this thing does really blow up and things do get out of hand and you know, the system gets overwhelmed, I think that does expose you or put you at risk if you're doing elective procedures. So it's something to think about. And with that, that ends my portion for now, and I'll turn it back over to Dr. Manchikanti.
Thank you, Amol. That was wonderful. I think all the presentations were wonderful. We will try to answer as many questions as we can in next 24 minutes. And after that, we will try to answer all your questions in writing and send you the emails. And if you didn't leave the email, please go ahead and let us know your email so we can answer the questions and send them. Here, I think I'm getting confused here. Which was the first question? Is the bottom one the first question? Last one is the first question, 2:50 p.m. Okay. how are other private groups handling lack of interventional procedures? Are physicians in the group taking pay cuts? What recommendation would there be contractually to ensure salary returns to baseline after pandemic? Amol, that is your question.
Yeah, sure. And it's a difficult one. Right now it's awfully early. I think most of the private practice groups haven't felt the pain of lack of reimbursement. And I think once they start experiencing that, I think for sure physicians are going to start having to take pay cuts, particularly ones that are RVU-based. There's some modeling of even employed physicians in southwestern Ohio. There was an article in the news showing that one hospital entity that had physicians employed by RVU-based models expect a reduction in salary of around 70%. I personally, I have my own practice. I care about my employees. I wanted to make sure they were getting paid. So I suspended my own personal salary for the time being to make sure I had enough dry powder to pay for staff. I think it's going to be dependent on the group or entity in terms of how they handle this, but I definitely feel like there'll be financial pain coming up, particularly within June or July. And I think that's why it's very important if there's free money out there from the stimulus package. As physicians, we've all paid an extensive amount of taxes into the system. Now might be a time to recoup the benefit, and it's for needed things, right? I mean, we're actually feeling financial loss from this. And if you don't do it, my concern is if this drags on, a lot of us may not be able to remain solvent and have to close.
Okay, next question is, what is the panel's stance on doing interventional pain procedures during this pandemic? I really don't see any major reason to do these procedures unless this is an emergency like a pump or a stimulator going wrong. Otherwise, we have to wait for these. CDC has classified these as elective procedures. And if we really don't have too many of the supplies, we should go ahead and donate them, equipment, etc. Meanwhile, President Trump appears to loosen the regulations by Easter Sunday, but then we have to think about the states. So some of the states may be able to do as of April 13th. States, I'm hoping Kentucky is one of them. I'm not sure Ohio will be there, but Kentucky, Indiana, Tennessee may be able to do, and all the states, I'm not naming all of them, but either way, we have to follow the CDC regulations and also the state regulations once federal regulations come up. Next question is, Dr. Soin, we manage 5 pain practices in Ohio, and our providers vary in some treating patients in their office, ASC, as usual, and others are not seeing patients in office at all and doing telemedicine alternatives. What is the general consensus here in Ohio for these alternatives?
Yes, thank you. Great question. Some of it's kind of easy to answer. Regarding ASCs, that's easy because Ohio has been pretty clear about wanting to shut down ASCs or have ASCs closed, and if they have extra PPE to donate it. And actually, the state medical board has been emailing people on a daily basis on information on donating PPEs. Regarding treating patients in the office, great question, too. The way that Ohio is going about this is encouraging telemedicine, just like a lot of other states are, but you can still see live patients in your office. They do ask that you practice social distancing, 6 feet apart in your waiting room, potentially having only the patient come into the waiting room, or even have them wait in the car and be texted when their appointment's ready, having patient companions to wait in the car, checking fevers upon entering the building. Ohio is requiring every single worker or employee to also have their fever checked and documented prior to coming into work. If anyone has symptoms or have been in contact with anyone with COVID-19 or traveled to New York, they can't be seen in the office, and it's actually suggested that they self-quarantine for 14 days. The big debate is about office-based procedures, and that's been a question that's brought up a lot of times. If you're using a lot of PPE, obviously that's highly discouraged. The Ohio Department of Health released some specific guidelines on doing procedures, and they kept them somewhat loose with physician discretion. There was one section in particular that said if the patient is experiencing extreme worsening of symptoms, that could be an indication that they may need or benefit from having a procedure done. With that, I would think that you would really have to make sure that you document why you're doing the actual procedure. I mentioned that our hospital and our system has a scoring rubric to stratify whether or not it even makes sense to go to a committee to do the procedure. And one of the things that you have to pass for a pain management injection is that the patient will have had to have failed adjunctive medication, including a trial of opioid pain medicine. Because, I mean, the reason why we do procedures is to alleviate pain, so they want you to try every possible thing prior to doing the procedure, including trial of narcotic pain medication if that's appropriate.
There are multitude of questions in relation to, are you going to use PPE during the procedures? Can you do the procedures if patient is in severe pain? What about the open procedures, SIJ fusion? I believe that everything falls into the same thing. We cannot do anything until CDC says that we can. And again, your state regulations may even extend them beyond that. So we just have to wait and see on that. Okay. What are the criteria to qualify for bailout money? Is it going to help our private pain clinics? Amol?
Yes, great question. And what I might want to do is, I think we have all your email addresses, is to email you a summary of the 748 CARE Act. First of all, yes, as a private clinic pain center, you absolutely will qualify for bailout money. You just have to have a small business with less than 500 employees. The key is how you did your payroll the year before. Because there's basically two types of loan options for you. One is just an SBA disaster loan, and you can apply for that by just Googling SBA disaster loan. It'll pull up the website, and there's literally something that you click down there, and that will take you to the application there. Now, there are some things with that disaster loan that are not as good as the payroll protection loan that I brought up, and that, in particular, I'm referring to the loan forgiveness aspect of it. So loan forgiveness becomes like a grant, right? A check of cash. And that loan, in my opinion, if you're going to do one, that would be better. Again, they want to look at last year's payroll, take that payroll amount, multiply it by 2.5 times, and that's probably where you can end up with your loan. And that can be used for stuff like rent, mortgage obligations, utilities, all these things that we use to operate our practice. I really highly, strongly recommend that you guys look into that. Again, this is an SBA 7A loan, and that particular type of SBA loan is administered by a bank, right? So it's not one that you necessarily would have to go to the website for. That's a disaster loan. But this loan that's forgivable, I would suggest you contact your local banker and tell them that you're interested in doing that, because the bank is actually the one that issues the loan. The federal government provides the money to the bank, and the bank is the one that distributes it from there. So please do that, and please look at that if you're in private practice at all. If you're to take one thing away from this, or actually two things. One would be try to avoid doing interventional pain procedures as much as possible right now. I think if something happens, it's going to be very difficult to defend yourself if there's a negative outcome. And two, really look into this economic stuff, because like I said, right now we're not feeling it, but you're really going to feel it in June or July.
Okay, there are multiple questions on NSAIDs and steroids, IV, epidural, so on and so forth. These are all for Dr. Davie, I think, and she has something else to add on. Malpractice carrier emailed her. We also received from malpractice carrier, as you know, ASIPP partners with NorCal. They are covering everything. They just want us to have a protocol on televisits. So if we write in our phone visits, we need to write in the protocol that how we are doing it, and it is supposed to be only phone if that's all you're doing, and as long as you have it in your protocol properly, you will be covered. Devi?
Oh, thank you. I just want to check. I think I'm still on mute.
Are you still on mute?
On mute. Oh, yeah.
No, you are there. We can hear you. Can you hear me?
Oh, okay. Now I can hear you. Sorry. All right.
Did you hear me? The question? Did you hear the question though?
About the malpractice?
Plus NSAIDs and steroids and vitamin D infusion.
Okay, so for the NSAIDs, as Vanila mentioned also, that there's some evidence, they think that the reason the death rate was so high in Italy could have been because people were using more NSAIDs, and that some of the people who were younger, maybe the reason they also were susceptible, because it didn't seem like they were susceptible initially in China, could have been because they were using high-dose NSAIDs. That's sort of a preliminary kind of report. It's not shown. So for us as pain management specialists, if we're putting people on high-dose NSAIDs and they could tolerate Tylenol instead, or maybe they use opioids, muscle relaxants, other medications, I would say, if they're already on those other medications or they could tolerate them, maybe better to move them that direction. But it's not clear that the NSAIDs necessarily cause a problem. So if your patient only responds to NSAIDs, nothing else is working, and that's been working well for them, you don't have to stop them from being on them. But I would say if you're prescribing it, I would probably put in the label too that, please try to avoid using unless necessary, as we discussed. For the steroids, the whole concept of the epidural steroids and these injections is that it's supposed to be localized, not necessarily affecting their immunity. But, with a lot of these things, it's sort of like you have to look at what other people think, what they believe, what other people are doing. And so for many reasons, like with the steroids, if there's a chance that it's lowering people's immunity and also it's an elective procedure, then I would say best to avoid it. The vitamin D, so this is based on, there's some research earlier, Tom Frieden also referred to it as well, but if people get vitamin D, it might help to stop this cytokine storm, like the inflammation that contributes to death here. So, that might be helpful for people. But let's say your outpatients at home are calling about vitamin D. Generally what I've seen is that they're saying if you tell them to take 1,000 units per day, that's probably a safe dose, whether they're low or whether they're normal or high, but that's a tolerable dose. But if they're going out and taking massive amounts of vitamin D, that also could have, present problems, especially because they can't easily get their levels checked. Vitamin C is another vitamin people are talking about. They're using that in the patients that are sick, even as IV infusions. For people at home, if they're using vitamin C or zinc as a multivitamin, that's probably fine, but we don't want them to have high doses of these medications or vitamins or minerals. I don't know if you guys saw, there was a report about a person who heard that chloroquine could be life-saving in COVID-19, so he basically drank all his fish tank cleaner and then he died. So people, when they're panicked, kind of take things sometimes to an extreme, so we want to just be cautious about that. What I was just going to add after Amol was just that we've been getting notices from our malpractice carrier every couple of days. I think it's because the situation is so possible your state would become like that after. So, initially they said that anything where you're providing direct care to coronavirus patients, is pretty much immune from liability. So if somebody's testing positive for coronavirus and you're trying to save their life and you do all kinds of things wrong, you can still be sued. So you can be brought to court, but you would be considered immune from liability. Then they kind of changed that a little and added, well, now that we don't know if the person has coronavirus or not, if you are doing activities to try to further the effort and try to manage any patients who could have coronavirus, then that would also be immune from liability. They haven't said that our patients, let's say you're trying to protect the vulnerable. So for example, I'm prescribing things that are not ACE inhibitors or ARBs to try to help them with their blood pressure. They haven't quite, made that immune from liability, but it might be coming. They said that if any educational effort, so for example, when I was writing the book, we're trying to prepare these things for them, for our patients to try to educate them, because I thought it's too much. They're calling and, I'm speaking to them, but because they have the doctor on the phone, sometimes it's very difficult to end the phone call. There's a lot of anxiety and all kinds of stuff. So that's why I was leaning towards sending things out by email. Those efforts are also covered in terms of liability and stuff for now. But like I said, anybody can sue you. It's just that if you ended up in court and you had to pay for the lawyer, you might have some costs, but you should be immune unless you're doing something that's grossly negligent. And then the other thing they told us is, let's say, now the disaster relief package has passed, but they warned us that before it passed, if we had closed our office, so let's say that I had said, you know what, we're not going to do this virtual thing, like this is too much, I'm just closing the office and that's the end of it. That actually is not allowed because that's considered patient abandonment. So, if you run into a problem like you have to lay off staff or some of this other stuff, just be cautious, like you don't want to fall into this patient abandonment category.
Thank you. This hydroxyquinolone and azithromycin, probably there is some evidence for that. And for those of us who were trained in India a long, long time ago, went to medical school, we used to go and pass on 2 tablets to everyone. And once a month or something, we used to have rotations. That is how malarial thing worked. And initially, when I came here, whenever we traveled to India, we needed to take 2 tablets of that. Now, that is what Governor Cuomo was saying, that in South Africa, there is no prevalence of coronavirus because almost everybody is on hydroxyquinolone. Then it is a very, very safe drug. We also do these things all the time in India. Now they are saying that India has been ordering all the frontline workers to take hydroxyquinolone before they go back to work, prophylactically. I don't know. I don't have any evidence on that, but we are also working on these exosomes and mesenchymal stem cells for fast-track approval from FDA. So if they approve it, we will have a clinical study soon. I have been doing that all morning today, working on it and getting the clinical sites to participate. We are going to include 64 patients for each mesenchymal stem cells and the other one exosomes and see if that works. So all the questions saying that it is not working, now we will know if it works or not. One question on telephone visits is there are multitude of questions. I think some of the folks are misunderstanding or whatever is happening. As far as Medicare is concerned, you use regular visits, and those are only telephone visits. You don't have to be a video on there at all, and don't need to document time. If you are billing on the basis of the time, then you have to document that 50% of the time was for counseling. So I don't recommend that at all. But you do need to add everything, all the components, how much pain relief they have had, numerically and percentage-wise, what is their functional status, quality of improvement. Then you go through their history, smoking, risk factors, if they're on opioids, other drugs, and how they are interacting with each risk factor. And also mention all the time that there is no history of corona either in the family or in the patient. That will be extremely important. When we talk next time, we are going to have very good seminar, and we are going to have 3 or 4 of these. After that, we will continue to talk about these at the annual meeting in September. It is going to be timely and relevant content. Some of the questions are, should we close the office? I don't think that is an option. This is not the first rodeo. We have been there. That is the reason why ASIPP was born. All the interventional pain management procedures were going to be removed. Now we have almost like an epidemic of interventional procedures. So I don't think we are going to go out of business. That is not an option. I don't think we should look at that. We have to be working hard to save our practices. Again, another question just came in. Can a telehealth visit be just over the phone under the current waiver? Yes, yes, yes. Only phone. but you do still document all these aspects on your chart. So we are coming to the close. Again, I want to thank all of you and the panel and Amol, and everyone has done a wonderful job. All in all, this went pretty well, except that we had a few audio problems in between 2-3 times, but it was not bad. So overall, we had 1,091 attendance, and we will see you again next week. It will be very important for survival of interventional pain management and pain physicians to provide interventional pain management. Thank you. Good night.
On behalf of ASIPP, I'd like to thank all of our attendees for your participation. We'd also like to thank our speakers for an excellent presentation. At this time, if you could fill out the brief survey that you should see on your screen right now. Your feedback is greatly appreciated. This concludes today's webinar. We hope you have a great day.